Okay, I have the great joy of talking after lunch about infection control in the middle of our second global pandemic in the last 3 years to a group of incredibly hardworking healthcare providers who I'm sure are not burnt out on talking about infection control at all. So I have tried to make this interesting and relevant, especially for people who provide frontline care. I spend a lot of my time in the back office thinking about infection control, and I think what I do and what we report to the CDC is probably not super relevant to all of you. So I'll share some of what I've learned in the last couple of years, where we are right now in infection control, which is unfortunately not in a great place, and some ideas for going forward that I hope is relevant to your practice, and then happy to take any questions afterwards. Does this work? Next slide, please. Okay, I have no relevant financial disclosures. Next slide. And so we'll talk a little bit about an update in healthcare-acquired infections and some of the recent epi news we have. That's the bad news. Then we'll talk about some important lessons learned from COVID. I think there actually has been some really good progress and some great things that we've learned that have made things in the monkeypox era much better already. So just a few months in, I think we're already in better shape. And then we'll talk a little bit about moving forward by getting back to the basics of infection control. Next slide. Next slide. Okay, so this is a recent report put out by the CDC just a couple of months ago. Perfect. That actually shows some pretty major step backs in the last couple of years. So if folks haven't seen this yet, I would encourage you to go to the website and look at specifics, but I'll share a bit with you today as well. So overall, we have seen about a 15% increase in antimicrobial resistant infections and deaths just in 2020. So we don't have subsequent data yet. I suspect it's even worse. About 80% of patients hospitalized with COVID, which we know is a viral infection, received an antibiotic in the early months of COVID. I think this happened for a number of reasons, and we'll talk about those a bit, but we think that's a problem as well. And then we have a lot of delayed data and a lot of problems reporting data on a lot of our usual resistant pathogens because we were so focused on COVID reports. Next slide. Okay, so what have the challenges been to infection control during the pandemic? I think none of these will be news to you. Advance, please. Okay, so the first, I think, was a huge shift of resources from usual infection control practices to totally COVID-minded work. I know I spent the first 12 months, I think, of the pandemic not thinking about a single thing other than COVID. I wasn't seeing patients in clinic, I wasn't attending on service, I wasn't doing my usual stewardship work, I was only thinking about COVID. I think our entire group did the same. This happened in every hospital, every long-term care facility across the country. I think we also shifted our pathogen tracking. We do a lot of work in all of our institutions trying to see what's being transmitted, prevent what's happening, and we didn't have a moment to think about that. All we cared about was COVID. So you can imagine if we shift everything away from the usual work, we're gonna lose some ground. Next. I think there were some pretty dramatic changes in antibiotic prescribing, specifically in inpatient settings and nursing home facilities and other long-term care facilities. If you look at those places, there were huge balloons in antibiotic use. Initially, I think we had some early data that made us think azithromycin might be useful in COVID. We had no approved COVID therapeutics. I think everybody, including myself, felt pretty desperate, and I think a lot of us gave azithro for COVID until we learned that that was not effective. So in 2020, that definitely drove antibiotic use, especially in long-term care facilities where we had very vulnerable patients. Outpatient antibiotic use actually dropped pretty dramatically in the early pandemic, which is cool. That's where most of our antibiotics are used inappropriately. That has not really persisted. I think people are having seasonal infections again, especially viral URIs, where we give a lot of antibiotics unnecessarily. We're back on track with that. So lots of antibiotic use shifts during the pandemic. Next. We, at least at our institution, had a lot of trouble following our usual infection control practices. I think several units in our hospital were so full of patients with COVID that we couldn't do our usual work. We also had a big shift. I don't know if anyone else's institutions experienced this, but initially when we didn't really know how to protect healthcare workers from acquiring COVID in the hospital, we had our nurses doing environmental cleaning in the patient rooms instead of our environmental services folks, because we just wanted the fewest number of people exposed. Turns out that was a huge error. Nurses are not trained to clean rooms. Nurses have a full-time job already. Asking them to participate in environmental cleaning in a room is not gonna work, and it didn't work for us. And really quickly we realized we need to get our environmental services folks fit, tested, and trained, and back in those rooms doing the work that really matters. I think also lots of healthcare worker burnout, which we're seeing now, contributes to people just not being able to do their regular job the same way they used to. And I think we are definitely seeing lapses in hand hygiene and all sorts of stuff because people are so exhausted from this pandemic. Next. We also saw a lot of delayed care seeking in our patients, and so by the time they finally showed up to the hospital, they were so ill that the locations in the hospital they had to go, the type of care they received, very aggressive interventions, and then discharge to long-term care facilities just puts folks at different risk for hospital-acquired and long-term care facility-acquired pathogens than they would have had they presented early. Next. Okay, and then longer hospital lengths of stay, which we see with COVID. Months and months and months of people being in the hospital with tons of interventions, definitely a setup. Lots of people getting intubated, getting Foleys, getting chest tubes, things that make it very risky to be in the hospital, very risky to obtain a hospital-acquired infection. We know we have seen that more in the COVID era. Next. Next slide. Okay, I think that was my last automated slide. I apologize for that. So digging into the CDC report, you can see just the pathogens that we've been monitoring for a long time and what the impact during the first year of COVID has been. So just to orient you, the CDC has determined some drug-resistant pathogens as urgent, some as serious, some as a little bit less severe. I've included the urgent and the serious, some of the serious here. On the left-hand side of that table is the pathogen itself. In the middle is what the trend was in 2017 to 2019. So were we doing well? Were we stable? Were we already struggling? A lot of these pathogens we were already struggling with. Some, though, we were doing okay, right? We were seeing decreases in C. diff infection in hospitals, and that was awesome. And then the pandemic hits, and you can see just how bad things are looking. Again, just in 2020. So when we see 2021 data, I do anticipate things are going to be even worse. So pretty scary. Carbapenem-resistant Acinetobacter, I don't know if anyone has seen cases of this or outbreaks in units in the facilities you work. This is a horrible pathogen. I see some nods. This pathogen loves to persist on curtains and on walls, and then once it gets into a unit, it's really hard to get out. We have certainly had outbreaks a long time ago in the facility where I work, and we never want to see that again. And yet, 78% increase in these infections in 2020 alone. So a little bit dire, I think, this report. I just also want to comment on Candida auris, which is the drug-resistant Candida, or the drug-resistant fungal species, which is the second line on this table. I think probably Dr. Dan already mentioned Candida auris in her emerging infections talk earlier this morning. This is an interesting pathogen. I'll show you a map in a second. But this is a pathogen that we also see dramatic increases in the COVID pandemic era. Next slide. We also, not on that table, because the table was a little bit big, we also saw increases in multi-drug resistant Pseudomonas during the pandemic time, up 32%, and MRSA, which is a pathogen that I think we are all used to seeing. Nobody wants to see, we see it all the time, but also an increase. So even in the common things, those are going up as well. Next slide. Okay, so just briefly about Candida auris. So this is a unusual pathogen that sort of originated a couple of years ago in several continents all at the same time. We don't understand why that happened. I think from the infection control perspective, a few takeaways about this pathogen are that it can harbor a lot of drug resistance, and I'll show you some studies looking at that in a second. It also is weird compared to other Candida species. So most Candida Candida that we see, lives on people's skin, colonizes our mouths and our guts, and sometimes causes infection when it gets into deep, scary spaces. Those are not healthcare pathogens. They don't persist outside of the human host. They don't tend to cause a lot of trouble, and so we don't pay too much attention to them in the infection control setting. Candida auris seems to be a totally different beast, and I don't think we really understand why, but this bug loves to live on walls, on patients' bed rails, all over the environment. Some people advocate for putting little pads with bleach on them outside of patients' rooms, like we do with Ebola, so that when we walk out of the room, our shoes get cleaned, because there's concern that this pathogen can stick to healthcare workers' clothing. So this is a very different pathogen, and once it gets into healthcare institutions, it likes to stay. So it is, again, a big problem, and one that I think we're all going to be seeing soon. It also colonizes patients' bodies and likes to stay there too. And then a lot of those patients go on to develop severe infections from this pathogen that then are really hard to treat. So it's a bummer. We don't want to see this pathogen spreading. We were seeing it in several places across the United States pre-pandemic. It is even more prevalent now. Next slide. Okay, so this is the map that you probably saw at this conference in 2019, where we had seen Candida auris in few places in the US, but certainly not everywhere. New York City, Chicago, California, especially Southern California, had a bunch of big outbreaks, but the rest of us were not seeing it much. All over the world, there are reports of outbreaks from this organism. So this is Candida auris. Next slide. So contrast that to the 2022 map, which shows us several other states are involved. We have not seen a case in Washington yet. The public health colleagues that I talked to about that tell me it's because we're not looking. It's not because it's not here, which makes me horrified. But we haven't seen any cases here yet. Oregon did have a case in a hospital maybe about 6 months ago. Someone correct me if that's not quite right, where the pathogen was diagnosed but not recognized immediately as a problem. And so I think for all of you, if you hear Candida auris, it was first diagnosed in someone's ear, so that's why it got that clever name. You call your infection control people immediately and have them call the state, because I think the last thing we want is this to go unrecognized for several days. But it does, looking at California, Nevada, and Oregon, it does really seem to be closing in on us here in Washington State. So I think it's only a matter of time before we start diagnosing this organism. The Washington State Department of Health does have fairly rapid PCR-based testing to identify Candida auris, and they are willing to work with institutions on screening of patients. So there is, I think, a huge opportunity in Washington to do great screening for this pathogen. The patients at risk are really folks coming from long-term care facilities, probably, into acute care facilities, or moving from long-term care to long-term care. So those would be great patients to swab. We at Harborview have not been able to operationalize that because it's really hard to identify in a big hospital who's coming in, from where are they going. What we do is screen folks who have been in a hospital or a healthcare facility in another country in the last 6 months. So we are screening a small subset of patients. You do an axillary and a groin swab, and then the Department of Health is able to run a PCR on that in a couple days. We have caught, as you can see by 0 cases in Washington, we have caught 0 cases so far. But it is possible we will catch a case one of these days. And we would love to start swabbing people coming from other institutions. Hard to say when that'll happen, but I think a reasonable and thoughtful group could put something together like that to start screening, because that's where we're going to see Candida auris in Washington the first time. Next slide. Okay, and this is just a study that came out of an outbreak in Southern California in skilled nursing facilities and LTACs, where they did swabbing. They saw a couple of cases, brought in a huge CDC team to do surveillance and interventions, and I'll talk a little bit more about this study later. But I think the really nice thing that they did was get all 137 isolates in the patients impacted and look at susceptibility testing. And I think that tells the story that's important for this organism. So way on the right-hand side there, you can see that 100% of these Candida auris isolates were resistant to fluconazole. That's like our go-to drug for Candida infections. Probably the easiest to take, definitely the most affordable, is out. That is not ever going to be an option for these patients. Amphotericin on the very bottom line, about 7% of the isolates were resistant. So not a horror story with the ampho, but a little bit concerning. That's usually our go-to drug when someone's super sick. We think they have a fungal infection. We want to reach for the best drug we have. So that's getting knocked out by some of these. And then the rest of the antifungals tested, especially the echinocandins, so caspofungin, micafungin, anidulafungin, whichever one your institution uses, were 100% susceptible, which is good news. Those are only available IV. They are expensive. They are hard to take. So we don't like patients to get infected with a pathogen that we only have IV options for. So again, protecting patients from being exposed to this is probably the best thing that we can do in our facilities to help prevent this spread. Okay, next slide. All right, so what are the highlights we've learned? After all of this doom, what has COVID actually done for us in terms of infection control? Any lessons learned? Are we in a better place now than we were before? I would say in some ways we are, and I'll try to outline them for you now. I also would love to hear after this presentation what other thoughts you have about things that we have learned that are going well, because I think it's important to have maybe this much hope if we can. Okay, next slide. So, a 22-year-old man, let's say it's July, King County, 22-year-old man presents to your office with 2 days of fever and malaise and a new perirectal ulceration that he reports as painful. He also says he had anal sex with a few male partners, one of whom just got diagnosed with monkeypox virus. So you swab the lesion, and it is unsurprisingly monkeypox. So from the infection control standpoint, I just want to sort of walk through this patient's care and why I think we're in better shape with our COVID precautions than we would have been had this monkeypox pandemic hit us 3 years ago. I think things would have been really out of control. Next slide. Okay, it's a timeline. There's a lot of nexts. I apologize. Okay, next. All right, so the patient comes into clinic, walks right in through the front door and up to your clinic's front desk. Next. The patient is greeted by the front desk staff. Next. The patient is then evaluated by an MA, an RN, a clinician, probably all three. Next. And then the testing is performed on this patient. Next. Okay, so I think, good things being good, counting our blessings, this patient actually, by mandate in Washington State, is already masked by the time they hit the door, which is a recommendation for someone with monkeypox. So patient already has a mask on. 3 years ago, not a chance that patient would have had a mask on, and that patient is masked for the duration of their visit, walking into the building, sitting in your waiting room for 6 hours, coming back to the clinic room masked the whole time, which I think is huge. Next. Often in healthcare facilities, I don't think all, and I think people are getting pretty quick with these questions, but I think patients also are much more ready to identify these symptoms and tell someone about them. These patients are already being screened for fever, chills, sore throat, in some places, maybe even a rash, probably more due to acting quickly in early May when we started seeing cases, or also people who've had measles exposures in the past. Oftentimes front desk staff are asked about that. In the clinic where I work, this patient reports a fever, gets taken right back to a room with infection precautions in place. 3 years ago, no one would have asked, no one would have known what to do, and they would have left him in the waiting room for 2 hours, potentially exposing tons of other patients. So I would say that's also good news. Next. Okay, staff are also already masked, which is the recommendation for monkeypox is that staff and the patient be masked, so that's a huge win. I think we also have more ready access to N95s than we have ever had before, and more healthcare workers who are fit tested to those masks. So also, I would say a win. Next slide. And then I think, the early days of monkeypox didn't go super well. We didn't get testing right away. But I think within a few months, we actually have really good access to testing for this pathogen. And I think that really was a lesson learned from COVID. In our lab specifically at the University of Washington, our laboratory colleagues were calling us in infection control and saying, do you think this is going to be a problem? Do you need us to make a test? do you need us to do it now? Do we need to run it Monday through Saturday? And we said, yes, 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 yes. We were like at case number 5 in the region, and they're already calling us and asking us this. And then within a couple weeks, we had a test online, ready to go, ready to use. They run it Monday through Saturday. So Sundays in our hospital are a little annoying, but otherwise things are great. And that feels like huge change. That never would have happened 3 years ago. I think that's totally a result of relationships built, trust built, and understanding of the urgency of these tests for infection control reasons. So I think all this in the timeline to say, I do think things are better, and I think we're a lot safer because of all these protocols and everything that we've learned. Next slide. Oh, and also we have an employee health team, exposure team ready to go, because they have dealt with all of the COVID positive employees for the last 2.5 years. They know the questions to ask, and they know how to help employees who are either exposed or acquired monkeypox in the community. Next slide. Okay, so this is the CDC monkeypox exposure assessment. They do have a community exposure version and a healthcare exposure version. Essentially, they rate the type of exposure by high, intermediate, or low, and based on the level of exposure, you are either to do monitoring or monitoring and post-exposure prophylaxis, which would be a vaccine against monkeypox, so the Jynneos vaccine, which we know is on super short supply. So next and next. So I think with the protocols that I just outlined, all of the work that we've done to prevent healthcare-acquired COVID in our clinics and our hospitals actually really prevent us from having most higher risk exposures and even several intermediate risk exposures. These things are just not going to happen if we're adhering to our COVID protocols. So I think that's really good news. I don't want any healthcare workers to have a high-risk exposure. It's incredibly disruptive. It's very scary. Giving limited vaccine to something we could have prevented feels, sort of fraught and a little difficult. So I am thrilled that we are already preventing these things with no additional work. And I think keeping healthcare workers safe and feeling safe interacting with our patients, which I think is critical as well. I will add that in the course of this most recent pandemic, there have been no cases of healthcare workers acquiring COVID from patients. There is a case report from several years ago in London, I believe with a healthcare worker who cleaned sheets of a patient who had monkeypox, and there was a thought that they shook them and potentially aerosolized stuff in the pre-mask era. So one case of a healthcare worker in all of time acquiring monkeypox outside of endemic regions, I think is pretty good news for the safety of this infection and the safety of our work. I do know we have a lot of concerned healthcare workers who really don't want this infection. And so making sure they know that, and also all the things that we're doing to keep them safe, is pretty darn important. But I feel great about where we are, especially given all the controls in place ahead of time. Okay, next slide. Okay, I also think in the pandemic we have learned a lot about masks and what those masks can do for us. I think there's sort of the pre-pandemic paradigm of I wear a mask to protect me. And this is really data in support of that. So this was a randomized control trial done in Bangladesh in 2021, where they randomized several regions of the country, very rural regions, to receive mask interventions, where they were given free masks, huge amounts of free masks, education, involvement of leadership in the area, all sorts of incentives. And we're able to show in that graph on the left there, compared to control regions, which didn't get those interventions, didn't get the free masks, there was a almost 30% increase in uptake in masking, which is cool. But I think really more importantly, in the middle and the far right graphs, you can see between the control and treatment arms, big decreases in the number of people acquiring COVID. A 10% decrease doesn't seem like a lot, until you learn that this was an intervention done among about 160,000 participants. And 10% of that is a whole heck of a lot of infections averted. And so I do think this is helpful. Also, 42% mask use, not awesome, right? We really want much, much more than that. We're in periods of huge transmission risk. But if we can get to 40%, we can prevent 10% of the infections we're seeing in the community, which I think is pretty encouraging news. Next slide. Next again, sorry. Okay, one more time. Thank you. Okay, so this is, I think, I can't say post-pandemic, can I? Inter-pandemic paradigm of mask use. And this is really not a way I had ever thought about masks before. Maybe you had. Maybe you were far ahead of me. I hadn't gotten there. That masks are actually helpful for preventing me from getting all of you sick. So masks as source control is really a pretty new phenomenon. I think there are other parts of the world where they really got this. In the US, we were not there yet. So I think now we have a lot of data showing that masks actually do work if I'm sick as well. And I think that's pretty encouraging too. So this is a study looking at surgical masks as source control. They looked at patients who had PCR-confirmed viral respiratory illnesses, and specifically dug into people with human coronavirus. So the graph on the top there is not COVID, but it's human coronavirus, so the seasonal coronavirus we've all been getting for our whole lives. The next graph below it is folks with influenza, which we know about. They also looked at rhinovirus. I didn't have room on the slide, but very similar looking results. I'm not sure if you guys can see the text there, so let me describe what these graphs show. So essentially, the two bars on the left with all the dots very high up, that was just confirming that people with either a nasal swab first or a throat swab second actually had virus, and they did. They had pretty infectious levels of virus. And then in the middle, they looked at people sort of expiring droplets when they coughed, when they talked, and they observed them for 30 minutes. The first graph there with a bunch of green dots and then some little dots above was when they were unmasked. Next to that, so the most middle section, was when they put a mask on. And you can see when you're talking and coughing with no mask on, you do spread droplets into the environment locally. You put a mask on, and those all go to zero. Which I think is awesome. Very encouraging and good news. They then measured aerosols, infectious aerosols in the room, and what they found was that with some of these viruses, a regular procedure mask compared to no mask, like with the human coronavirus, dropped those aerosols to zero, which is fantastic. Flu, they went down, but they didn't go down all the way. So wearing a procedure mask probably helpful to decrease the infectious aerosols you make when you're talking and coughing and hanging out, but doesn't drop it all the way to zero. But I do think surgical masks, we now have ample evidence that these are really helpful so that I don't give you my illness. Next slide. But how do we get to zero? Like if I'm sick, I don't want to make any aerosols. And how do we prevent that? So this is an interesting study that NIOSH did looking at N95 respirators. This is a simulated study, so they use saline instead of infectious particles. So they aerosolize saline in these NIOSH studies, which is a smaller particle than any respiratory droplet or any aerosol I would make, and so a much more sensitive study than had we done it with a real viral pathogen. NIOSH has been testing masks for years, and they have a setup where they put a mask on a blower, and the air blows through, and they measure these saline particles, and what they want to see is 95% of them not get through, or only 5% get through, which is why it's an N95. And what they did was just flip it. So they put the blower, before they were doing it this way, mask, preventing the blower, things from getting inside. And they just flipped the mask around on their measuring device. I'm sure it was much more sophisticated than that. And they blew the saline through it as if the blower was the wearer of the mask, and then they measured the particles that came out. I think this was very clever, nice way to look at source control. So over on the left there, you can see is a sort of mathematical modeling of what came out when they used that blower machine. And in someone with an N95 respirator with no valve, very few particles came out. So source control with a respirator with no valve is probably exceptional. So if you have COVID and you need to wear a good mask around other people, I would wear a respirator, an N95 if you can, fit tested if you can, with no valve. The middle is looking at, those respirators that have the valves on them that are meant for comfort when you're using them, not for infection prevention. So they looked at people wearing those, or the machine wearing those, and you can see some particles got out, but not all of the particles got out. And so maybe those valves are not totally terrible, but not quite as good as without them. They did also put the little EKG sticky on the inside of the valve and showed that it went to 0. So that's encouraging if all you have is a mask with a valve. And then the mannequin on the far right there is a cloth mask. So respirators are good, really good for source control. And I think that's exceptional news and something we have not known before. Next slide. Next again. Okay, and then I think the other thing that we've really learned in the pandemic is a deeper community-wide understanding of the hierarchy of controls, which is a healthcare environmental safety model that we adapt to infection control as a way of thinking about how to keep ourselves safe. And so I think we understand much better now that elimination is key. It's hard to do, but it's probably the best thing we can do to protect ourselves and our healthcare workers and our patients from infection. And that PPE is good, but it's probably not nearly as good as the rest. And all of the other hierarchy in the middle there. I think we now have a much more intuitive understanding of this than we ever had before the pandemic. So I think good news. I don't know, it's not perfect, but I think we're doing a little bit better in some realms. Next slide. Okay, so how do we move forward? How do we as individual healthcare providers sort of move the needle and try to do a little bit better to prevent some of these infections? I think it's really by getting back to the basics. Next slide. So really, for all of you in this room, I think it's being really intentional about hand hygiene, using PPE when there could be an exposure. I never knew this as a medical trainee. It wasn't until I started working in infection control that standard precautions means wearing gloves and a gown when someone has diarrhea in front of you. I had no idea that was a thing, or if someone was coughing that I was supposed to put iPro on, or if I was suctioning them, I should cover my eyes. But really thinking about the practicality of preventing us from acquiring infections or spreading them to their neighbor, I think is something that we have the capacity to think about. We understand more about how infections are transmitted than we ever have before and can implore these things. And then I think keeping the environment clean is probably one of our most important interventions as well. So I'm going to share some studies, some silly, some really interesting, that have recently caught my eye, but sort of emphasize all of these ideas. Next slide. Okay, so this is a hand hygiene study. I think we all know we are supposed to wash our hands on our way into our patient's room, wash our hands on our way out of our patient's room, and we all are terrible at doing that for a number of reasons, not because we're malicious, terrible people, because it's hard to remember. You think you're just bopping your head into the room, and then you get called in, and you forgot to wash your hands on your way in. You just washed them 14 times, and you're still rubbing them from the prior room. I think there's a lot of reasons we don't do this well. Turns out there's a lot of social factors also involved in washing our hands. So if our attending washed their hands, then we are way more likely to wash our hands than if they didn't. So lots of interesting things. But there are increasing requirements on hospitals and healthcare facilities to provide hand hygiene audits. So monitored, I sat outside the door and I watched 40 people go in and out of rooms, so 40 opportunities, and 90% wash their hands. We have to report those to regulatory agencies. It's a huge amount of person time. It's not a very fun job for anyone, and there's also some bias from I know I'm being watched, so I'm gonna wash my hands. So the reporting agencies know about all those problems. However, they're requiring us to submit more and more and more and more observations. So probably we're all gonna move electronic at some point. We have a little thing on our badge, and as we walk through the room senses it, knows there was a hand hygiene opportunity, and did I use the gel or not? Probably we're all moving in that direction. So some people were like, maybe this is an opportunity to see if this actually helps. Since we're gonna move in this direction, period, is it a good thing to monitor people electronically? So this intervention, they set up in tons of hospitals, monitored for 3.5 years what happened when they put RFID badge readers on people's badges and hooked those up to the doors. They put these on almost everyone, but not everyone's badges. So nurses, MAs, physicians, physical therapists, dietitians, anyone who could go into a patient's room got these RFIDs on their badge. But folks, like patients' families, didn't always get them. And so what they looked at was how much gel was used on a unit. So let me orient you quickly. On the y-axis here is the average daily use of hand gel. On the x-axis is time. The line in the middle of the graph is day 0, so when they started the intervention. So we're sort of watching people wash their hands at 30%. That's really unusual, but maybe an honest reporting. Most hospitals report 90% compliance with hand hygiene. Sorry, that's not 30. That's the amount of gel used. So I don't know what the proper amount of gel used would be, but about 30 amounts of gel used per day is their standard. And after they do this intervention, the black line, or the solid line, is the total units amount of hand gel used. So they put RFID codes on everyone's badge, and suddenly, huge increases in use of hand gel, which is really interesting and pretty cool, and something I think we all would want to do right away. Next slide, please. Next. Okay, but unfortunately, I said they monitored these hospitals for 3.5 years. I think what they found was on month 20, you can see peak use of hand hygiene. And then after that, it started to dwindle and dwindle and dwindle and dwindle and dwindle. And overall, again, just looking at the black line because the other lines are some interesting subsets. If you look and you scrutinize, people actually stopped using these badges, were uninterested, and their baseline level fell to slightly lower than where they started. So though these interventions can be helpful and awesome, and I think we're all enthused right away, I think they're not going to be the silver bullet that we wish they all were. It's something that is going to need ongoing maintenance, ongoing reminders, and unfortunately is kind of a bummer, I think. Next slide. So somebody else came up with this interesting idea of like, what if I put a watch-like item on all of my healthcare workers? Maybe that could help. And this watch will monitor how much they gel, but it also will remind them when they go through a door or get close to a patient's room. If they haven't gelled, it will vibrate. And it also has a light on it that turns red or green so that the patient knows whether they gelled or not. So like the ultimate in accountability. And they enrolled this in a couple of ICUs. And I think, again, everyone was really enthused. This will be a great thing. They start off, they hand them off to all their staff, and 90% of people are using them in the first month. And then over time, this is just use. So whether people are wearing them to work or not, you see huge, like enormous decreases in the amount of people willing to wear these things. They actually smartly did a survey and asked healthcare workers, why aren't you wearing these things? And the biggest complaint was that they are inaccurately capturing what I'm doing. So I go into the room and I gelled. I have gel in my hands, and it's buzzing and it's flashing red, and the patient thinks I didn't do it. And I'm not getting credit to do it. And that was a huge problem. So I think reliability of these things is going to be critical for making them work. Next slide. But they did increase hand hygiene, even when people weren't really wearing them. So on the x-axis is pre-intervention, with the line, the intervention period, and then post-intervention. And the black dots are the study units. So the study units where they had these fancy bracelets actually had declining hand hygiene going in. And then they slapped these bracelets on their healthcare workers. They didn't all wear them, and their hand hygiene rates went up. So I think there's something buried in there that says good news. But I also don't think, these things feel really appealing. I would love to wear a bracelet that reminds me, but certainly not if it gets it wrong. And I think I would tolerate getting it wrong very infrequently, especially it's flashing red at my patients. So not a super encouraging intervention. We are all trying to learn what is the best way to get people to wash their hands. I don't think we know. There's been really cool studies where we look at putting up posters with people's eyes. And if you have eyes on a poster, folks feel like they're being watched, and that increases hand hygiene. Turns out the first study of this was like huge, and everybody loved it, and then the repeat studies haven't really shown this effect. So I don't know. There are a lot of social factors, but I think if you guys can take anything back to your institution, it's making sure that folks are washing their hands and getting creative about the ways that you do that. At my hospital, we had a competition for like a reminder word, because I don't know if any of you have ever asked someone to wash their hands, but it's very awkward and kind of difficult, and nobody likes to be called out on not washing their hands. So instead of saying, hey, you didn't wash your hands, we had a contest and voted on a word that would be our institutional word for reminding folks to wash their hands, and it was Jell-O was the word that won, which I kind of like, right, for hand gel. It took off for a while, again, got lost in the pandemic, but I think coming up with ways within your clinics or in your institutions to sort of normalize calling each other out is probably the best way forward, because we're not going to have an electronic solution for this. Next slide. Okay, another recent study that caught my eye that I thought I would share with all of you is the lack of benefit for contact enteric precautions for patients with C. diff. So this was a randomized control trial published in Clinical Infectious Diseases a couple of months ago that showed the green is baseline and the blue, or the blue squares, is the study period. And they showed in their control and their intervention ICUs. In the intervention groups, they basically told people that you should wear gown and gloves as standard precautions. So if you're cleaning someone's poo, somebody's having diarrhea, and you go into the room, you would wear those things, but otherwise, you can just use standard precautions. And as you can see, no benefit, which is wild, right? I think all of us use the full gown, gloves, hand washing every time we see a patient with C. diff, potentially for months after we see those patients, depending what institution we're in. I think the caveats here are this was a hospital with single patient beds, not a lot of long-term patients, and really good hand hygiene rates to begin with. But interesting, an interesting question to what we all do all the time. There's been a lot of talk, at least among the ID crowd in the last couple of years, about waste of PPE, and this might be a good example of where we're wasting unnecessary PPE. My hospital's not going to jump to adopt this because we have a very challenging space, but I will look forward to seeing more studies like this, but definitely a question to our conventional work. Next slide. Also an awesome study that I suspect a lot of people have seen. It was a New England Journal study in 2019 that looked at decolonizing patients who had a diagnosis of MRSA. So either colonized or infected with MRSA, thousands of patients included in this study, randomized to receiving decolonization or just receiving education about their MRSA infection. The people who got randomized to decolonization did mupirocin in their nose and chlorhexidine bathing. They did it 5 days in a row, twice a month for 6 months. So pretty intensive. Mupirocin in the nose is the worst. Feels really funny, patients don't like it, and it's expensive. But if you can pull this off, they actually then monitored patients for return admissions or clinic visits for MRSA infections and saw a pretty interesting drop from 9% to 6%, which was statistically significant. So I think a lot of patients feel pretty helpless when they are colonized with MRSA. I think this is data to support that this intervention might be useful, and they tell us how to do it, which is really nice, because I never quite know how to decolonize people. For how long, with what interventions, how many times a month. I just use this study protocol now and feel like I have a nice intervention to provide my patients that won't save them all, but a good proportion of them. Next slide. Okay, and then finally, just thinking about environmental cleaning. This is going back to that big Candida auris outbreak in Southern California among nursing care facilities and LTACs. The CDC drop crew came in, they did a ton of education, they swabbed all these patients, and they looked for environmental cleaning opportunities before they got there and after they got there. So in the third column is before, at all the individual institutions after. And I think what they found was they could increase environmental cleaning from about 50-60% to 70-80% in these facilities, which is, again, a little disheartening, right? The CDC comes in and they tell you what to do, and you can only get to 80%. But they were able to decrease transmission of Candida auris extensively in these facilities. I showed you before there were 147 patients being transferred among these units who were infected, and they got down to 2 facilities with 1 patient each at the end of this intervention. So we don't have to be perfect. I think that's what this teaches me. We probably will never get to 100% anywhere with any intervention, but doing well and doing better might be enough to eradicate these pathogens from causing us problems. So if you can't get your people to 100%, I think that's okay, and I think it's still worthy. Same thing with hand hygiene here in the second column, not 100%, but also still we're able to dramatically decrease the number of pathogens being transmitted. Candida auris, which is a sticky, scary, horrible bug. So I think this is great. Next slide. Okay, so takeaways. 2.5 years into the pandemic, we are gonna see lasting impacts on healthcare forever. I think the biggest one in my world is gonna be all these drug-resistant pathogens we're transmitting about. It's gonna take us years to fix that. I think there's a lot of setbacks in stewardship, and hopefully you guys all heard about that this morning as well, how we're gonna continue to push the envelope in that direction. But I think we also have learned some important lessons, and I feel pretty encouraged about much of what we've learned, and I think it is gonna impact the way we deliver care and how we keep our patients and ourselves safe. So get back to the basics. That's my message. There's a lot we know how to do. We just have to remember how to do it. And with that, I'm happy to take any questions.
All right, thank you so much for the summaries and all the lessons we learned from COVID and all that. I have one thing about one question about the Candida auris. We know the risk factors if they are long-term care facility resident or LTAC patient. So what else make you worry? We have to test them. Are they just colonization? Because you are checking the skin swabs, right? Are they similar to the colonization, like for example, MRSA in the nasal cavity? So anyway, and so what make us worries? What the symptoms, what the signs?
It's a great question. So I think the concern is that patients who are colonized can do one of 2 things. Either cause colonization of the institution, which then causes colonization of someone else. If this was a pathogen, just lived on people's skin and caused no problem, I think we would tolerate that and not care. But the other thing that can happen is that these folks can go on to develop a deep infection from the pathogen that first colonized their skin. So we think that's how it happens, right? You've never seen this pathogen before, it doesn't live on your body, you get exposed, it causes colonization, lives mostly on your skin. Axilla and groin is just the convenient places we swab, and then can set up and cause a deeper infection. And people who get this pathogen can have very bad infections. So urinary, which is weird, we don't see that with Candida much, but we can see it with this. Pulmonary and pleural infections, and we do see bloodstream infections with this pathogen as well. So that's what we're really worried about, is this progression to real disease.
Other things that I like the way you put a few things like the new interventions, like use new technologies of wearing bracelets to check if you have the hand hygiene done properly. But I really don't think it will really work because it's a bracelet and it can carry something else and make things worse. But anyway, it's interesting to see the thought of how to help us remind ourselves. And also I like the way your comment on the contact precaution for C. diff infection. Yes, sometimes I feel like if we are not touching the poops, why? So anyway, it's good to think about the conventional work we did. We take it just granted. We think it's what we did, it should work. But anyway, that's just a comment. And let's see, do we have any questions?
So you're talking about how you are getting into equipment for monkeypox, but how is that different? What would be safe for when you're out just in the clinic? Most clinics don't have, I mean, we have gowns, we have eye protection usually, we have gloves, but we don't have like respirators, and so.
Yeah, so the question is for monkeypox, especially in settings that might not have access to respirators or especially fit-tested respirators, what should we do to protect staff? The CDC recommendation is that folks are in respirators. I think probably not necessary. We do like to follow CDC when we can, but if it's not possible, I think we go with the things we know, which is source control. So we want the patient masked the entire visit. I think for most patients, unless they're complaining of oral or pharyngeal lesions, it's probably unnecessary to see, or face lesions, it's probably unnecessary for them to unmask at all. And if they need to, I would make it brief. And make sure the healthcare providers are in the best fitting, highest quality mask they can be in. So I would not let healthcare workers in with cloth masks, but unfit tested N95s, or what you're wearing right now, a really nice, well-fitted KN95. I would feel pretty good about that. And then when you're examining lesions, gloves. We want you in gloves. The CDC rec is gowns and gloves, which most people have access to. I think probably the most important intervention there is having gloves on and making sure, I don't know, we've had some healthcare workers touch monkeypox lesions unknowingly without gloves on, and that's been very stressful and really scary. And so what we're recommending is any old rash, please wear gloves, because that's what's going to be the majority of protection. But I think, we're not seeing infections transmitted to healthcare workers. Makes me feel like our N95, fit-tested, eye protection, gown and gloves is probably more than we need, and that's okay. That's what we want it to be, but I think we can do things really safely even without all of that.
Any other questions? All right, thank you so much.
Thank you.